Okay, and I'm going to start out by being a bit of a dork. So, a lot of parents, I think, when their kid comes home and says, "Mom, Dad, I want to be a sex therapist," they'd be kind of terrified by that statement. But my parents weren't. They have been the most amazing, supportive people ever, and they're watching right now. So, hi, Mom, hi, Dad. So, and I think what's really cool is that my father worked in healthcare, and so talking about health was always something that we had at the forefront of our household. We'd have family dinners, and matters of physical well-being and emotional and mental well-being were prioritized. And that included sexual health, because sexual health is a very important part of your overall health. Every single person in this room has the capacity to experience sexuality. And if we pretend that that's not the case, then honestly, it's a bit naive, and we're going to do a lot of harm and damage to not only ourselves, but to our kids who are growing up, learning about their bodies. And none of us want to do that. So it is my goal in life to empower people to feel good about their sexual selves so that they can make the right choices for their body and feel like they are in charge of their health, they are in charge of their lives. And so I am so excited that Mindy was kind enough to invite me to moderate this panel of questions. So without further ado, let's get started. So, Dr. Cote, how does MS typically affect sexual function? Actually, you know what? You just discussed that. That was fantastic. So in that case, Allison, what role can pelvic floor therapy play in managing MS-related sexual dysfunction?
Well, the pelvic floor, in my opinion, is the root of all health, right? So we poop, we pee, we want to have sexual intercourse. And if we can't do those things, we aren't living our best self. So the pelvic floor contracts to help stop and store urine and stool, and it relaxes to help release urine and stool, but it's also that contraction helps facilitate orgasm and successful orgasm. If you're pooping your pants, peeing your pants, not pooping, not peeing, or you have pain with penetration or achieving erection, you're not going to want to have sex. So the pelvic floor is kind of where that all happens. And my job is to help you understand where that is. We don't know where it is. We understand where our bicep is, but we don't understand where our pelvic floor is because it kind of lives inside us.
Okay, thank you so much. Dr. Cote, I'm dying to know, what else did you want to say in that presentation? You were doing so great talking about, I'm just going to dive into the prosthesis because I think that that's really important to know. So can you tell us a little bit about the prosthesis?
So I will say, initially in my search, Safe Search was on in my computer because my children also use that computer.
Yeah,
so first I had to navigate that. But so there was an evolution in the prosthetics. So there are versions that were older that were like these malleable rod versions. And so patients might be familiar with those too. So it's not just the water pumps. I like the water pumps, but there are other prosthetic styles out there. But what I like about the water pump is that when it is deflated, it is fully deflated, and no one would know that you have anything surgically implanted. Malleable rods are always semi-rigid. And so to me, I think that also comes with a risk of trauma if something is semi-rigid and implanted into soft tissue. And it's slightly visible to the exterior world as well if you have that all the time. But so these prosthetics are low risk, fast outpatient, and generally really no signs that anything's been done and can last a very long time. And they're on demand as long as you need it, always ready to go. And so implant can be done in people, 30s, 40s, 50s, 60s, 70s. So there is not necessarily, an age cutoff for this. So, and it can be triggered by a partner. So say you don't have the dexterity to activate this. If you have a partner that you trust, they could activate this for you. And that still allows you that time together I think these are great. I don't know. I actually have the perfect patient for one, and I cannot wait till I see him next, because as soon as I saw it, he was my first thought. And my husband also treats him, and I told him, and he's like, "Oh my God, he'd be great for this." And I was like, "I know, I can't wait." So
I'm so excited for
that
your
was part of my
patient.
excitement. Yeah.
That's fantastic. So I will say I have also had many patients who have had prosthetics, or they've had implants for penile to enhance erections, and people are very, very happy with them. I will say I've noticed more partnered pain with the rods than with the water-filled tubes. So that's something to be cognizant of what's the experience going to be like for your partner, because you don't want to have an implant done and then unintentionally create a new form of sexual dysfunction. So make sure you're asking your provider a lot of questions about not only how's this going to impact my sexual function, but any potential partner sexual function too. Yeah. So, okay, I dropped my sheet. Excuse me. How frequently, Dr. Cote, would you say issues of sexual health come up in your clinic?
So that is partially my fault, because I was not asking. So patient initiated, infrequent. Yeah.
I commend you for making changes to that. How about you, Allison? How frequently are you talking about sexual health concerns in your clinic?
Every day with every patient. And honestly, any patient who walks in our clinic door that's not my patient, I will probably talk to you about it too. Or your bowel health or bladder health or whatever. So yeah, I talk about it a lot. You might come in to me to talk about urinary problems, and I'm going to ask you about sex. You might come in for constipation, and I'm going to talk to you about sex. And you're going to say, well, I'm only here because I'm not pooping. I'm like, cool. That's a problem too. So it's all related. I talk about it all day, every day, to people's horror probably. But patients come in all the time and say, ugh, you don't want to know this. I'm like,
oh, yes, we do.
Tell me it.
Yes,
Tell
we
me
do.
it. There's no secrets. There's no shame. I hear it all. You are not alone.
I feel the exact same way. But I mean, I'm a sex therapist, so people know that they're going to be talking about sex when they talk to me. But yet some people are still, very reserved, which is understandable. It's a very challenging topic to discuss. But I'm very vocal about what I do, because I think it's, again, important to normalize this very valid part of the human experience. And so, I'll be, talking to a stranger, and they'll ask me what I do, and I tell them, and then I'm there for 20 minutes talking about all of their sexual health experiences, and that is a consistent experience. And I bet that's what you have with your personal life too.
Yep, sure do.
Yeah, so
it's fine.
And people are so eager to get answers, which I think is just such a call to us as providers to be more proactive when talking about sexual health concerns, and then also a call to our patients to know, this is okay to talk about. We want you to talk about this. Even if a provider may be uncomfortable themselves, it's okay to have your provider be uncomfortable. That's on them, okay? Because honestly, some providers are uncomfortable. But again, that's on them. It's important to ask about your health and get appropriate, healthy responses.
Can you show slide 39 of my talk? And can you comment on, if you have an opinion about it, the intensity?
I've never seen it. From looking at the picture, it looks like an internal electrical stim device.
Yeah. So the intensity it's FDA approved, and it inflates and strengthens the Kegels. And it's also a clitoral stimulator. So it's FDA approved for improving orgasms, but also strengthens the pelvic floor at the same time. But it's FDA approved device, and around $220. So I was hoping to show the picture in case anybody was interested.
So a lot of pelvic floor therapists will probably gasp when I say this. I probably train Kegels less than any other physical therapist ever, specifically in the MS population. If we already are having spasticity, especially spasticity in the pelvis, you are likely having spasticity in your pelvic floor. That might present as what we think is weakness. I'm leaking urine or stool, therefore my muscles are weak because they can't hold it in. Where really they're tight and they're spastic, and now they're tired. And now that fatigue has caused that release of our contents. So all of that to say, cool, but maybe we don't need to overtrain a muscle that's already really tight. Again, unlike our bicep, we can see that our bicep is like this. We can see that our legs are scissoring together. We can't necessarily see what we're doing with our pelvic floor. So I would caution against using an internal stim device unless you've seen someone who specifically is like, no, you have a ton of weakness. I do stim on my MS patients because there's that feedback loop that's missing. Some of that, like those signals from the brain aren't hitting the muscles in the pelvic floor, and we need that sensory awareness to better know where those muscles are and how to activate them. But that would be my my only caution is, unless you know that your pelvic floor is specifically weak or you don't know how to activate it, overdoing Kegels can be a bad thing.
Are there surrogate muscles that you can use to gauge that? Because we can usually use neck flexion to gauge respiratory weakness. So if someone has normal tone in their lower extremities, can you use that as a gauge? Or how do you gauge that? Because if the rest of the body is normal tone, would you presume that there's pelvic floor spasticity?
Hypertonicity versus spasticity. So someone consciously holding their muscles tight versus or consciously holding their muscles tight. So I tell people all the time, if you're sitting here and talking to me, are you consciously sucking in your stomach? Are you consciously squeezing your glutes? Are you tensing your jaw? Are you holding tension somewhere else in your body? And if the answer to that is yes, you're likely also holding tension in your pelvic floor that you don't need to. So let it go. A physical therapist somewhere once probably told you, if you have back pain, keep your core tight. And you internalized that as, I'm going to keep my core tight all day long. That's not how the core is intended to be used. That's not how the pelvic floor is intended to be used. So maybe that, I don't know if there's as much researched validity behind that. There is research that tension in your jaw core produces tension in your pelvic floor, but I don't know.
Yeah. There's so much about pelvic floor physical therapy that is just amazing and so far beyond my level of conception. And a sex therapist absolutely love pelvic floor physical therapists. We think that they are wizards because they really do magic. If your provider recommends you check out pelvic floor physical therapy, please do it. It's wonderful. As a sex therapist, as someone who works in a lot of vulvar disease and vulvar pain conditions, and sees a lot of issues with penetration or confidence issues with how your body's working, please go see your pelvic floor physical therapist. Okay, so I'm going to answer a question that is directed toward me, and because it's one of my absolute favorite subjects to talk about, and it's probably the most common topic that I discuss with people, and I love it because as soon as I'm done, I'm going to be able to look across the room and people are going to be nodding, yes, that makes so much sense. And that is the issue of sexual desire. Dr. Cote already alluded to this is a very big concern for a lot of individuals impacted by MS. It's a very big issue impacted by everyone because I gotta tell you, Disney and porn lie to us. Shocking, I know, right? But not every romantic relationship that we have is going to be perfect. Not every sexual encounter we have is going to be amazing. It's not going to go how you think it's going to go most of the time. And that is reality. And a lot of us have this idea in our mind that we should really want sex all of the time. Or we should really want sex when it's date night with our partner, or when they look really attractive, or whenever it is in your mind that you think you're supposed to experience it. Well, I gotta tell you, The term sex drive isn't actually accurate. So it's made its way into our vocabulary, and it's really good at helping us understand this natural experience of wanting sex. However, it's not technically accurate. And Dr. Cote, please correct me on my neurobiology and my terminology if I get this wrong. However, my understanding is that a drive is a mechanism which is basically meant to keep an animal alive, like hunger and thirst. We have a drive to attend to these needs, and if we don't have them, we're going to experience tissue damage and we could die. But nobody has ever died because they didn't have sex. Sex is a want. It is not a need. Therefore, it's not a drive. And I tell people that just to give some relief, like, oh, wait a second. You mean it's normal if I don't have this pull to pursue sexual activity? As a matter of fact, a lack of interest in sex can often be a sign of good judgment. Okay? So it's normal. And so, well, why do we want to have sex then? Well, we consider it an incentive motivation system in the brain that says, hey, if the context is right, this could be a fun experience to have. Well, then what controls that desire? That's a two-part system in the brain because the brain really likes balance. Okay, it's called the dual control model of sexual response. There's the excitatory system and then the inhibitory system. But basically, it's like a car. You've got an accelerator and then you've got the brakes. The accelerator is pressed by all of the reasons that you want to have sex. Your partner looks super sexy. You want to have an orgasm. You got really into book talk and are reading all of these romantasy novels, and all of a sudden, like, all the erotica is everywhere all of the time. I have fun facts about erotica and its impact on female arousal, but I digress. Maybe you want to get pregnant, or maybe you were just exposed to some sexually relevant stimuli. So if we talk about sex, it's normal for our bodies to get a physiological reaction. So that could have happened. So that's going to press the accelerator. But then on the other hand, we have the brakes. The brakes are all of the reasons why we don't want to have sex. And like Dr. Cote said, maybe you're super stressed out. Maybe your partner was a jerk that morning, or they have really bad breath, or you have 8 different doctors to go to and you can't remember which one is which. Okay? So if you think about all the things that are overwhelming, or maybe you're having a really challenging day with your body, or maybe you're in pain. I got to tell you, pain is something I hear about a lot from a lot of folks. Those things are going to slam down on your sexual brakes. And if we think about a car, is a car broken if the brakes are pressed all the way down and it doesn't go when you hit the accelerator? No, just like no one is broken if their sexual brakes are pressed down and shockingly, they don't have any desire to pursue sexual activity. That is a normal response. I'm seeing a few nods. So if you're experiencing challenges with your desire, you got to check in and be like, what's going on with my accelerator and my brakes? And so that's one of the very first things that I talk about with patients. And I really encourage you to consider for yourself as you're exploring how MS is impacting your sexual function or that of the people you care about. Okay, now I'm done with my little monologue there. Thank you for letting me say that. It's one of my favorite little speeches to give. So, okay, Allison, how do you assess and tailor treatment plans for sexual pain disorders in MS patients?
Okay, so shocking, but the MS patient is the same as any other patient walking the door. Your anatomy is the same. How your muscles work might be a little bit different, but how I assess you is going to be the same. So if you've ever been to any other physical therapy or occupational therapy, we look at how you move. I'm going to ask you tons and tons and tons and tons and tons of questions. You get an hour with me specifically, so we're going to use that time. I'm going to ask you lots of questions. I'm going to get to know your story. I'm going to look at how you move. I'm going to look at what your muscles do from an external perspective. And then we will do an internal exam for people who have vaginas. That means we're going to do an intravaginal exam, kind of similar to the exam that you would get at a gynecologist's office. However, there's no stirrups, there's no speculum, there are no scary tools. It is a gloved, fingered exam and the goal of that isn't to be super invasive and icky. The goal of that is to feel the muscles that live inside your body and see what they're doing, right? Are they contracting? Are they relaxed? Are they super tight? Do they feel like rocks when you touch them? Is that why you're having pain? Are you having pain because the muscles in your pelvic floor are so tight that they don't know how to relax, that if you are being penetrated, you're hitting a hard wall, right? And then we're going to talk about things to do to make those things better. Again, like in other physical therapies, I'm going to give you stretches. I'm going to give you meditation exercises. I give every patient a meditation exercise very first visit, regardless of why you're coming to me. And we're going to do stretches and different exercises to have better awareness of what's going on with your pelvic floor and how to treat it. We'll talk about sex. We'll talk about positions. We'll talk about toys, devices, strategies, all sorts of different things that we've kind of touched on already. We will talk about in detail. And then when you come back, we'll talk about how did that go? What can we change? All and make tweaks. And it's 100% tailored to you as the individual. The MS disease is just a little asterisk, right? When you're with me, I'm treating you. I'm not treating your disease. We're talking about what your problems or your impairments are. And the MS component might just tailor how we do things because of how your brain and your muscles are working together a little bit differently.
Thank you. That was really thorough. I really appreciate that. That gave me a better understanding. Because again, I'm a fangirl for a pelvic floor physical therapist.
I should say, if you are a penis owner and you are a person with a penis, we do that internal exam rectally, because that's how we can access the pelvic floor. I guess the most similar would be to like a prostate exam, but not quite as aggressive. And if you're having bowel dysfunction, we do a rectal exam as well.
Thank you. Okay. I am loving hearing these different perspectives. And I think it's really important to know that it's good to have a treatment team. I love working with physicians and pelvic floor physical therapists. And when we have the ability to communicate and work to build a treatment plan with giving all three of our perspectives, it can be really, really beneficial. So add to your team if ever possible, and sign the releases so that we can all talk to each other, so we can share our treatment plans and figure out the best way forward for you, because everyone's going to have different priorities. And if we're communicating about what those priorities are and those goals are, we can make sure that you're going to be happy with how the plan is put into place. Okay, so along that lines, I want to hear how each of us would address concerns with bladder and bowel function. So, Dr. Cote, if someone comes in and they're really, really upset about how their bladder and bowel function is impacting their ability to experience sexual intimacy, how are you going to address that?
It depends a little bit on in what way. So we spend a ton of time managing bladder and bowel in general. Bowel, most patients will have some degree of constipation. Fecal incontinence, overflow incontinence happens as well, but the majority is constipation. And most important is just a really good bowel regimen. And you really want to aim for a nice, smooth appearing, nice log bowel movement a few times a week is really what I would like to see. If it's pebbled, if it's balls, it's too dry, it's been sitting in the intestines too long. So I always ask people what it looks like, and they're like, I don't look. And I'm like, I do. Look at all of them.
Do you have the diagram that you pull out? The Bristol stool scale?
No, but I tell people it exists, and they're like, what? Yes.
I would also add a really skinny stool that looks like a pencil is also not ideal. So, or like ribbon poop, we don't like that either.
Nice, smooth, soft serve log. So we spend a lot of time working on bowel regimens. I also have some great contacts in the spinal cord injury space who help when I really need assistance with more complicated regimens that I can't figure out. But really the key is consistency with using them, and really retraining. If someone has, reflexes, sometimes we'll talk about, digital stimulation or You know, foods to really help with keeping the gut healthy. And I love a good probiotic and prebiotic, and bladder stimulators I actually like quite a bit too, because that can cut down on fecal incontinence if that's a big issue for patients. So, you know, based on the bladder issue, sometimes we'll go the route of stimulators. With bladder, you can have issues with holding of urine. You can have trouble with voiding, where you're not always initiating the stream well and you're holding onto the urine. You can have issues with overactive bladder, where the second your brain thinks about it, it's ready to go, whether or not there's an amount worthy of the urgency. And people can have both. You can have a mixed picture where it's both slow to release the gates to let the urine out, but also urgent to do so. So it can be a little complicated when it's that mixed picture. And bladder medicines can be great at managing those symptoms. Like, bladder is actually not a harder symptom to manage. But from that list I showed, that's one of those medications that can affect libido. Bladder medicines often cause dryness as well. So I also often like bladder Botox quite a bit, and recommend that often. You can also do things like posterior tibial nerve stimulation, which is a nerve stimulator behind the ankle that can talk to the pelvic nerves and help bladder function. And if you've got a lot of money to burn, and you're willing to burn it, there's even fancy chairs you can sit on that do shock things to your pelvis that affect bladder function. She shakes her head no. I'm not a urologist.
Don't spend your money on it.
Yeah. It's like $3,000. It shows a lady reading a magazine fully clothed on a chair. My friend bought one for his clinic. He tried to charge me, so I said no. I said if it was free, I would do it, though. If he's watching this, sorry. But really, it's tailored to the patient. But ultimately, my preference is to get away from daily medications when I can, and use Botox or the PTNS, or really bladder stimulators too, because patients end up taking so many medications. And so if I can give them a break from that, I also like that if they're a good candidate.
Great. Thank you. Allison, how about you?
That's what I do all day. So we talk about all of it all day long, right? So again, if we're talking about constipation, if you're full of poop, you might just not feel good, right? You don't want to be intimate. You feel gross. You don't want something else going inside of you when you already feel really full. So how can we get you pooping? What can we do to help with that, right? Again, that might not be the reason why you come into the clinic. You might come in because you're having pain with intercourse, and we might realize that pain is really because you're super constipated. Constipation is the root of all pelvic floor evils. I promise you, more people are you can poop every single day and be constipated. Okay. So correcting constipation is huge. From a bladder perspective too, again, if you're, especially in women, the urethra lives in like right at the top of the vagina. If a penis is being inserted, it is rubbing, there's friction on the urethra. If you feel like you have a hard time controlling your urine, that sensation at your urethra can make you nervous. It could make you leak. It can cause a whole slew of things, especially if you have a history of leakage, right? So overcoming some of that awareness of what's going on with your bladder, how to control your bladder, all of those things. Why are we having pain? How can we correct our pain? What position are we using? We talk about all those things. So bladder and bowel function and sexual function are kind of synonymous if there's a problem. There doesn't have to be a problem. You can have ones without the other. You can have perfect sexual desire and constipation, bladder problems. You can have bladder problems with sexual desire or sexual desire without those problems. So, or intimacy problems without bladder and bowel function. So don't think that like it's this terrible road down because you have one of those things. Now you're going to have all of these things. They don't have to all go together. They can be separate entities. They just commonly kind of cascade together.
Great. Thank you. Okay. So you highlighted on something really important there, Allison, I think, and that's addressing pain. Okay. It is not normal to have pain with sex, any type of sex, unless you want to. Okay. So undesired, and I know that sounds kind of funny, but undesired sexual pain is not normal. And it is something I want all of you to address with a medical provider. Go to a medical provider first before you come to a sex therapist if you're having sex with pain, because that really needs to be explored and the origins of that need to be determined before we do any therapeutic approach. As a matter of fact, that's the case for all sex therapy. We want to make sure that you are addressing any physical causes of sexual dysfunction before we realize, okay, this is psychological and we need to process it with various forms of sex therapy. And it's like erectile dysfunction. If I see, a gentleman or a person with a penis who has erectile dysfunction, I absolutely make sure they see their provider before we even have a second session, because there's a really good chance there's something could be going wrong with their heart. So now when it comes to bladder and bowel, from my perspective, the two concerns that get brought up are pain or shame. Okay, so if it's pain, I first off make sure that you've addressed that with your medical provider, and then I help you understand you should not push through pain. If you try and push through pain, it is only going to make things worse, both physically and psychologically. A lot of people think, oh, if I can just tolerate this for just a couple more minutes, my partner's going to be happy. We can get through this experience and it'll be fine next time. That's not what's going to happen. You're going to cause harm to yourself, and then you're not really being honest with your partner, which is really, really difficult in a healthy sexual relationship, because communication is critical. Honesty, vulnerability is really necessary to have a good sex life. So please, please, please do not push through pain. Okay, so find a different sex act. Sex is any touch that's given with erotic intent. Penile vaginal intercourse is only one option on an endless buffet of sexual activities that you have to pick from. So if it is leakage, whether it is urine leakage or fecal leakage, I first validate that's really distressing. And that's a really shameful thing to experience, because in our society, we shame normal bodily functions. And that's just ludicrous. Everybody pees, everybody poops, everybody makes different fluids. And we need to normalize that. Sex in and of itself is very messy. Right? It is, again, not like what we see in TV and movies where people have experiences and they just walk away. There's going to be cleanup involved, especially if you're doing what I recommend everyone does, which is use a good lubricant. Uber Lube, that's my favorite. So recognize, okay, this is normal to have, some type of fluid coming out of my body. And so, if it's urine, recognize that urine is almost sterile. Is that correct, Dr. Cote? Mostly. Okay, so that's what a urologist told me, so I've been running with that. But so get towels, get potty pads, get anything that you want to lay down to help protect your furniture, your floor, and recognize this is okay to have it be part of the experience. You acknowledge that it's there, and then you keep moving forward. Kind of like when you're meditating. If a thought pops into your head, you acknowledge that it's there, and then you move forward. Okay. And you focus on being mindful of the contact with your partner or with yourself and the sensations that feel good. If you feel more comfortable and it is safe for you, you can move to a shower and have sexual activity there. You and your partner can shower before sexual activity, after sexual activity, make it part of the erotic experience, and just talk to your partner. Communicate about how you're feeling, whether that is anxious, worried. You might be anxious that they're judging you or thinking negatively about you, and they're like, oh my gosh, we get to have sex. This is awesome. And they haven't even given two thoughts to the fact that you might be leaking urine. So talk about it. Do not internalize that shame, and make accommodations. Everyone's going to at some point in their lives. Everyone's going to have to make adjustments related to sex because the body does what it wants to do, and it might be different every time. So, okay. How much time do we have? What time are we allowed to go till? We have 10 minutes. Okay. So, what I want to do first before we do questions from the audience is I want to know, what is one piece of information from your specialty that you want everyone to know?
No is a complete sentence. Yeah.
My favorite quote or statement is every person has a pelvis, and every pelvis has a pelvic floor. So pelvic floor problems are not elderly people problems. They are not female problems. They are not pregnancy postpartum problems. They are problems that can happen for every person everywhere. And again, there's no shame.
Unless you are experiencing unwanted pain or you are in a coercive or abusive dynamic or relationship, your sexual experiences are normal. If you have fantasies that you're like, where the hell did that come from? Congratulations, you're normal. There's a ridiculous thing called Rule 34 on the internet, and I love when I get to bring this into presentations. But if you can think of it, there's a porn of it online somewhere. And in my experience as a sex therapist, that is absolutely true. So again, unless you're experiencing unwanted pain or are in an abusive or coercive relationship, you're completely normal. All right, questions from the audience.
Hi. Do men Kegel? Can they Kegel?
Yep,
Shut up.
absolutely. Can you stop or try to stop your flow of urine? Please don't do that. Don't sit on the toilet and try and stop pee. It's not good. You shouldn't be able to do that. But that sensation of trying to stop your flow of urine or hold in a fart is a Kegel. In the pelvic floor world, we say, like, lift your sword, fly your flag. For men, that's your Kegel. The question was, how can we all be reached?
So I'm at Memorial Healthcare in Owosso. So for that, you just call and make an appointment. April knows how to find me.
I work for the University of Michigan. I am at the Canton Health Center. To see a pelvic floor physical therapist in the state of Michigan, you need a referral from your provider for it to be covered under insurance. That can be any provider. Your neurologist can write your referral. I love when I get referrals from neurologists because that means that you're talking about it with your neurologist. So any person, anywhere, you just need a referral. Note that U of M has 5 locations with pelvic floor PT, and our wait list is stupid, for lack of better words. So be patient. There's at least like a 2 to 3 month wait at all of our locations.
Okay, to reach me, so I'm at U of M as well. I'm going to tell you, I am not accepting patients, and the Center for Sexual Health is not accepting patients. We haven't been for about a year because our wait list is still over a year. It was 2 years, but that just shows you how many people need support with their sexual health. And there's only about 6 of us that do outpatient sex therapy. If you need a sex therapist, on the resource list, there are instructions on how to find a sex therapist. But if you have a question, I am a sex nerd and I am happy to answer intellectual questions. And that you can reach me at my email, which I don't know if there's an easy way for me to get that out to you, but I can just tell you. It's AMSIE at med, MED, umich.edu. Is it in the resource list? I don't remember if I put it in there. Okay.
Mindy has our emails.
Perfect. Okay. Thank you so much. Okay, I forgot to say one thing that I think is really, really important, and then we're going to get to these questions. The goals of good sex are not orgasm, they're not erection, they're not lubrication. The goals of good sex are connection, intimacy, and satisfaction. And good enough sex is good enough. So don't try to have like Olympic level sex and be disappointed when it doesn't get to that place, because you got to be realistic. Go into it with realistic expectations of, I'm going to have such a fun time connecting with my partner and getting to feel pleasure in my body. So I'm sorry, I forgot that and really wanted to say it. So Allison, this next question is for you and Dr. Cote, you as well. What can I do about constipation?
My fast and ready tip is fiber. Increase your fiber intake. If you enjoy oatmeal, make oatmeal and put ground flaxseed in it. Fiber, water intake, and movement are going to help with your GI motility. The gut likes movement. And so if you're sedentary a lot, movement. Go to yoga. Go do the things, right? You can do belly massage. If you look up the I Love You constipation massage, that will really help with GI motility and getting things moving. Squatty potties can help with positioning. Really, relaxation is huge. So if you're on the toilet and you're stressed about being able to poop, you're not going to poop. Sit there, breathe, relax, and just kind of try and let go. It's a weird cue, but my favorite cue, if you're having a hard time evacuating your stool, if we strain, we're closing the door. Okay, so we all know straining is bad, but we don't know why straining is bad. Straining causes the pelvic floor muscles to contract and it shuts the door. Instead, you want to relax. And the cue that's weird, but it works, is think about pooping out your belly button. So if you do that, your belly button goes down and out and your pelvic floor will relax and your stool will go down and out. So when in doubt, poop out your belly button.
That's amazing. I have never heard that. That is awesome. Dr. Cote, anything to add to that?
I'm going to think about that next time. Just that sometimes patients will rely or reach for laxatives, and overuse of laxatives can lead to a dependence and reliance on laxatives. And so as easy of a fix as that may seem, it can actually get you sort of stuck on them. And so I think you really want to be careful if you find yourself reaching for laxatives. That's really a sign that you want to reach out to your healthcare team to get a real plan in place, because the laxative route can get you in trouble kind of quick.
Okay. What should I do if I get leg cramps with orgasm? Dr. Cote, any thoughts?
So I will say that orgasm can actually help spasticity and can actually decrease it. So what often triggers spasticity, though, is the way a muscle is moved and the speed at which a muscle is moved. So if there's a direction that when you're moved a certain way tends to trigger a cramp. One, I think, is just education going in of like, moving me a certain way tends to elicit it. I think being mindful to be in a position where that's less likely to be triggered may be a good idea. So, perhaps you're on your side, or perhaps you're in a position where you're less likely to aggravate that muscle. But if it does occur, typically stretching, warm heat are going to be, our first options. If you have a vibrating massager, you can put that on to try to help work out that cramp as well. Sometimes topical, so like a blue emu oil, or if you have a topical CBD product, sometimes patients will try that on a cramp as well. And then lastly, if you have like rescue medicines, your doctor might have given you like low doses needed. Rescue medicines for breakthrough spasms could be another option.
A note on orgasms. If you are having difficulty experiencing an orgasm because you're trying and trying, remember that having an orgasm is kind of like falling asleep. The harder you try to do it, the more difficult and frustrating it's going to be. So make your goal, again, pleasure and satisfaction. Just like when people are struggling to fall asleep, I recommend make your goal relaxation, right? Rest your body, allow your body to have the experience. Don't try to force the experience. Okay, one more question that I have here. I've heard you should urinate before and after intercourse to avoid UTI. Is this true? Dr. Cote, I'm going to go to you.
Totally. Please pee after you have sex or after you do things. Please pee. Please clear out that urethra. Because, yeah, anything rubbing around there, even if it's by yourself, like after you have masturbated, women's urethras are really short. So bacteria does not have a far distance to travel to get into the urinary bladder, and urine is like the perfect broth for bacteria to like grow and repopulate. So men are luckier; their urethra is a lot longer for things to have to travel, but a woman's urethra is super short. So if you have been reaching around and moving fluids around down there, please urinate after.
Okay. Did somebody have their arm raised in the back there? I see maybe a few. It is 8:01. I am always happy to keep talking, very much like you, Dr. Cote. I will talk and talk about sexual health all day long. I was talking about it to my son's school librarian, and now I'm on the committee that designs sex ed at their school. So, yeah, that was a win. Okay. I also have a question up here. So do we have someone ready? Oh, we don't have a microphone. Okay.
I have both neurogenic bladder and bowel. Neither one works. Pelvic floor therapy sounds great, but I wonder why you think my neurologist, urologist, and gastroenterologist have never told me about that option.
Because they don't know we exist. I'm completely honest, and they don't think that we can help you. But we can give you strategies. I can't change your neurogenic bladder and bowel, but I can give you strategies. Yeah, they frankly don't know we exist. There is a huge boom in pelvic floor physical therapists, but it's still like probably less than 1% of physical therapists. I don't know. That was a completely made up number. Don't quote me on that. But it's still a really, really small market, right? So in my brain, there's tons of pelvic floor physical therapists because I associate myself with them. But in reality, there's just not a lot. And the same way that doctors don't know to ask or talk about sexual health or bladder bowel stuff, they don't know that we exist, and they don't think that we can help them. They just aren't educated. Ask. Usually they're totally okay with PT because it's a low risk potential reward, right?
I will say for every patient I've ever sent, all have had a good experience. None has ever come back and said, "What were you thinking?" I can't say that about other types of therapies that I have ordered before, but universally, pelvic floor therapy has had a good feedback.
Wizards, they're amazing. Ask your doctor, seriously. Okay, so we have a couple more questions. I have a feeling this is going to kind of keep going. One is a question about sexual dysfunction, sexual dysfunction symptoms, whether it's tertiary or psychological. I'm going to maybe reference your slides for that question because there's a couple other ones. And this next one's kind of a big question of how do you bridge the gap between caregiver and lover? And that's really challenging. And it's something that impacts so many relationships where chronic illness is involved. And the short answer, because this is something you could spend hours in sex therapy talking about, is change the setting. Okay, so we get into patterns, we get into routines where, one person is the carer, the other person is the person receiving care. Really work on changing the framework of your care partners. You're in it together, but make it novel. I'm a very big fan of scheduled sexual activity, right? So you can anticipate, so you can plan, you can prepare. Maybe if one room in your house is where you do a lot of medical intervention, where you take your medication, maybe we don't have sex in that room. Maybe we shift into a different room where we can feel a different part of ourselves, where we can stop being a person who has MS and get to being a really fierce sexual creature and have MS not be in the bedroom during that experience. Okay, so novelty, changing things up, and talking about it, talking about the struggle, bringing it out into the open and say this is hard because I'm exhausted doing this. I'm exhausted providing care. I'm exhausted receiving care. But maybe for tonight, we put that in the back burner and we talk about our past wonderful sexual experiences that we've had together. Or we talk about our connection. We focus on that intimacy. And that intimacy, building that, relying on that will really help bridge that gap. Okay.
Okay, just a couple more quick ones here.
Yeah, this really isn't even a question. It's more of a testament to the pelvic floor activity. I did that a couple of years ago, and it worked immediately. Part of it is just reconnecting in my opinion anyway, your brain for the sensation that you do have left down there. And it improved things 10 or 20%. It didn't get me from 0 to 100, but I just wanted the audience to know that it is a real thing. I think it's under discussed, but it's effective.
Thank you.
And pelvic floor therapy help with when the sciatic sets a lot of things off because it's all interconnected?
Yeah, absolutely. So, I mean, we treat the whole body, right? So if you're having sciatic pain, back pain, imbalance, whatever, it can definitely impact your pelvic floor and, bladder bowel control. So yes. If we're waiting for another question, I have another quick little tip. So if you leak urine, and specifically if you leak urine with changing of position or picking something up or bending, squatting, moving, my little strategy that you all can take home today is blow before you go. So it's a strategy by a therapist named Julie Wiebe, who's amazing. But essentially you're going to actively blow out like you're blowing out birthday candles as you change position. So if I'm going from sitting to standing and I know that I tend to leak urine when I stand up, I'm going to blow out as I stand. So I'm going to take my breath in and then and as I blow out, that's going to kick on your pelvic floor and help kind of pull that up against the gravity pulling down. Okay, so you all can take that home, my little free therapy session for you. If you leak urine with position change or picking up a toddler or a child or grocery bags or something like that, if you were to leak urine doing that, blow out as you do the hard part of that movement and it'll kick on your pelvic floor.
Okay,
Great.
any last
Yes,
question?
there is one last question that we didn't get to. So, Dr. Cote, this is for you. Okay. Can you explain the tertiary group for sexual dysfunction and what were the changes from the psychosocial that you mentioned?
So the tertiary was really getting into sort of the depression, anxiety, body image, kind of a lot that you really covered. So I'll be honest, I'm more primary and secondary. Tertiary is going to be this one over here, which is why they have the 2-year wait list.
Okay, yeah. So whenever you have a major change to your body, a major change to your identity, right? It's gonna cause a bit of a crisis of self, of who am I with this diagnosis? Who was I prior to this diagnosis? And how am I getting to know my body again? How am I feeling safe in my body again? As we go through life, our society is so stupid. I really hate all this emphasis on a particular way of looking. We say, if you do not look like this image that is represented in our culture as ideal, then there's something wrong with you. Well, reality is none of us look like that, and we're not going to look like that, and our bodies are going to change. And we can still be sexy and desirable and happy and joyful and ability to experience and stimulate immense sexual pleasure just as we are. But that sense of self becomes threatened when our conceptualization of reality has been threatened by a diagnosis, whether it's for ourselves or for a partner or a loved one. So get mental health support. There are tons of resources. Please don't suffer in silence. If you're experiencing overwhelming sadness, shame is so toxic because shame hides in the shadows. I think y'all are in the age group where you can appreciate Gremlins, a Gremlin movie reference from the 80s. So Gremlins were these terrible little creatures that like came out in the dark, and they caused havoc and mayhem. But when you shined a light on them, or when daytime came out, they died. Or they perished or something like that. You understand where I'm going with this. If we bring up those dark, icky feelings, those feelings of shame that hold us back into the light and talk with people about them, then they lose their power and control over us. So talk to people you trust and lean into the new normal. Okay. Thank you all so much.
Okay, Mindy and I said that you guys need to do a podcast together.
This would be such a great podcast. We have to talk to you after. You girls work really well together. All right. So thank you to our amazing speakers, our panel. This was beyond our wildest dreams when we started putting this together, right, committee? Yeah, they're smiling. They are happy. Yes, they are. Good night, everyone. Thank you for showing up for yourself and each other. On behalf of the whole entire Yoga Moves MS team and community, we are deeply grateful for your presence. Namaste and sweet dreams.